Thanks for joining. We're starting the first of a series of probably 4 to 5 classes on insurance billing fundamentals. A lot of times what happens at a hospital is there's so much turnover, and the person that's left is training you, and they may have exposure for what you do or do not do, because ultimately we're filling a spot for somebody that left. And then I'm more of a conceptual guy. It doesn't do me any good to know what I'm supposed to be doing unless I know sort of the understanding or the background or the reasons why. So we take we wanted to take an introductory approach to here's what it is I'm looking at, and then hopefully that lends itself to a better understanding of specific things we're putting on the insurance claim forms or how we try and go about it. So this is an experiment, but today we're going to start with the revenue cycle experience and how that feeds into different areas of the claim form. So whether you know it or not, you signed up for an insurance billing or follow-up position, but instantly you became part of what everybody in healthcare refers to as the revenue cycle. And so this is the chart that just sort of diagrams what we mean. When you think about the revenue cycle, it's everything that happens to the patient from the time they walk in the door until they cut us that last check for their experience at the hospital. And typically when we look at billing issues or challenges, a lot of people will point their finger at the business office, but you can see every area of the hospital impacts whether or not we generate a timely bill and how fast we get paid on that bill based on the quality of the data. So what I'd like to start with is just an understanding of you and I are all patients, and how our patient experience translates to the different claim forms that you'll be looking at. At a high level, insurance billing is broken down between institutional claim, which they also call the UB. It's just a abbreviation for the uniform billing claim, and the 1500 or the HCFA or the professional charges. So if we thought about radiology exam as an example, this is a bad example for critical access hospitals because typically all our charges end up on the face of the institutional claim. But in a radiology visit, you have a charge for going through the CT machine, and then you have a charge for the radiologist to tell you what that image means and whether or not you have a lump on your throat. So at a real high level, if you can think of the world in terms of institutional claims and professional claims, that's a real easy way to simplify what we're looking at. So we'll talk a lot about HCFAs or professional claims or 1500s and institutional claims or UB bills that go out, and that's what we're talking about at a high level. So you and I are sick and we walk in the door at registration, and if we're doing things right, which all of our facilities are, wink wink, what happens is you sit down to register for your visit, and before you go back to run that test, they ask you for a proof of ID so we know where to send the bill. The great example of this is my uncle is 90 years old and hasn't left the state of Montana, and he got a bill last year from a hospital in Kansas because they didn't get the right William Barth down on the encounter. So patients think it's silly, especially in a small town, but that proof of ID is real important to guard against healthcare identity theft. And then when they show us their insurance card, we run a transaction with the insurance company called eligibility verification to understand and make sure that the card they just gave us is valid and it's the right policy number going to the right insurance company. Depending on what kind of test you run, that you may or may not need a prior authorization. And then at the time of service, we also collect copays and deductibles based on your agreement with the insurance company. So on the insurance claim form, if I was following up, somebody said Scott's claim went wrong, pull the claim form and call the insurance company. The patient demographic information is going to be located here. Their claim number or their ID number with the insurance company is here. And
wait a second. Where are you at? Am I supposed to be seeing something on here?
Oh, you're not seeing my screen. That's an important first step.
Waiting to view. It asked me, are you waiting? There it is. I see it. I got it.
That'll be a lot better for you. Sorry about that.
That's okay.
So what we're walking through is the different stages of the revenue cycle. And what we should have been pointing to, I apologize we weren't sharing the screen, is that the patient demographic information is located here. That ID number that we get is here. And if they need a prior authorization number, it goes right down here. Now, 1,500 is a lot smaller and a lot simpler, and if you think about what goes on at a hospital, there are 8 to 10 to 15 different departments, and we have to be able to represent all of those on one claim form. But on a 1,500, it's just a provider charge and an amount, so there's a lot less data and a lot less complexity on but just navigating the 1,500 patient demographic information, ID number, prior authorization number if you need it, and then patient relationship. A lot of times what happens, if you see a denial that you get back and they ask you to follow up on it and the insurance company comes back and says, this patient isn't our insured, it means we either didn't verify eligibility where we go in and take a look at that ID number and make sure that it's still active with Blue Cross, or it's my dad's policy, but we said it belonged to Angel, and so that revolves around what we call the patient relationship, which means dad has the policy and wife and children are also insured. That's a different legal relationship than if Scott owns the policy on himself. And so a lot of times when you're solving technical denials where they say the patient isn't our insured, it either has to do with a bad policy number or bad relationship data relative to who's the actual owner of that policy. So the patient, we successfully register them, they get a face sheet, and then they go back and receive care from the hospital. This says that we have to have good clinical documentation in order to be able to bill for the charge, and our folks in HIM coordinate and review the provider's documentation to make sure that we've documented what we need to be able to legally bill. And then depending on your software, how charges drop to the claim. So what's the mechanism that generates the bill for $800 for my x-ray and $200 for the provider to tell me what the x-ray means. Then depending on the type of test we order, sometimes we have to collect from the patient what's called an ABN. It's an Advanced Beneficiary Notification. And an ABN says your doc is concerned and wants to run some tests to figure out what's wrong with you, but according to our grid that we've come up with, and Medicare and Medicaid developed this, so those are typically the vendors, they say that the diagnosis that you've gotten, so let's say a chest cold doesn't match the procedure that we want to run. So let's say it's x-ray of your foot. And so patient, you can go ahead and get an x-ray of your foot, but we don't think Medicare is going to pay for it, and you understand that and go ahead, that you may be responsible for it. Those are extreme examples, but that's the easiest way to simplify what we think of in terms of what's called a lack of medical necessity. Typically that doesn't happen a lot. If we run 100 tests, we probably run into 4 or 5 that probably don't meet medical necessity. And we can get into in subsequent classes what that means, but those are the pieces of care delivery that impact whether or not we're going to be able to bill. Because if that test didn't meet medical necessity, I had the flu and they wanted to run a head CT. As soon as we go ahead and run the test, that issue is set in stone about whether or not the hospital can get paid for it. So we talked a lot about clinical diagnosis, what our friends across the hall in HIM put on the claim. We talked a lot about charges. So your charges end up dropping in the meaty section of the middle here. And then if we had to get what's called an advanced beneficiary notice or an ABN, it ends up generating a modifier on the claim, and the modifier goes immediately after the procedure code. So if we think about the 1500, then again, a lot simpler form. The diagnosis codes, the procedures, and any modifiers. Actually, they have a separate spot for all the modifiers on the 1500. So this is probably rudimentary, and we can stop in case I'm rambling. I tend to do that a bunch, but I think it makes us a lot more laser focused in subsequent classes than when you say you've got a problem with a modifier and you know exactly where to look. Or the other reason I found out, I was spending a lot of time calling insurance companies, and then I was thumbing through the file to look for all the questions they asked us. They have to ask us a bunch of questions whenever you call an insurance company to make sure that we're authorized and they're not disclosing what's called PHI, protected health information. So we're in compliance with HIPAA. And what I realized is I could open up a claim form and find all the data on the face of the form. So I didn't have to be thumbing back and forth, and I was a lot more efficient on the calls. So that's why we're breaking it down into a base level understanding of what's going on. Is this too elementary, or is it useful at some level?
No, that form is useful. Lorinda gave me a form that was highlighted, different boxes highlighted and what the boxes meant.
Yeah.
But it is completely different from what I'm looking at, from what you're showing me.
Okay.
And actually the claim forms that you've shown me are what is in Cerner.
Yeah.
That's what I'm pulling up out of Cerner. So I think
Okay.
hers was just kind of a generic thing.
Sure.
Showing insurance IDs and codes and yeah.
Outstanding. Well, good. And so at any time, feel free to say, yeah, I get it, or that's too easy. But for me, a lot of insurance billers, they throw you in the deep end of the pool, and they just say, call Blue Cross and ask them what's the deal. And so we've taught this a lot of times, and sometimes it sticks a lot more for people than others. And so I wanted to connect every element of the revenue cycle to where that washes out on the claim form, so we just sort of have a snapshot of what's going on. We don't have to dwell as much because the rest of this piece goes a lot faster. So the patient leaves and we code. Now, every facility you go to, whether it's a hospital in Thermopolis or a hospital in Miami, has what's called a standard delay period. And that means if I left the hospital today on the 5th, there's a period of time where no bill goes out because we want to let the doc get his notes in, and we want to make sure that the lab had time to enter all of the charges, so we're not sending 10 or 15 copies of the bill. So for the first, at Hot Springs as an example, the standard delay period is 5 days. Nothing will happen for this patient until 5 days from today. Some people want to eat into a term you hear a lot is days in accounts receivable. And if we wait for 5 days before we generate a bill, we sure can't get paid before then, right? So some people will lower that term to 3 days, and they ask a lot more out of their department managers and to be firing things off and make sure it's in there. Coding also reviews the provider documentation to make sure that the doc got everything she needed in there in order to charge. And then they also serve as a charge guardian to make sure that if I came in and saw the doc and they cut a mole off my back, maybe the doc was good and she dropped a charge for the office visit but forgot about the procedure. And so they're sort of our last eyeballs on the claim to make sure that all of our charges are complete. So again, diagnosis codes, you'll hear the insurance company say that it's not medically necessary based on that diagnosis code, or and here's where the charges are going to impact. And then again, this document's not going to get generated by, you're on Cerner at Hot Springs, it's not going to get generated for 5 days from the date of discharge. And our activity dates are located here on the claim, and then individual dates of service if it relates to more than 1 day.
Okay, now this form, that form you were just on, is the one I'm looking at from Lorinda.
Okay.
Looks just alike. Okay.
Yep. So this is the institutional, and probably these are we spend a lot of time working these because they're typically have a lot more dollars associated with them than the provider claims, because it's just a provider fee or maybe 3 or 4 provider fees. And so we tend to make a lot of time and a lot of hay here. But it's also critical to understand 1500s, because we have a rule set up that if I sent Angel a bill every time it cleared the insurance company, she'd get 1 bill from us after Blue Cross was done here, and another charge from us when the Blue Cross was done with the provider visit. And we've set a rule up that said that's probably pretty bad for the patient experience. And so we're not going to send any bills to the patient until both the UB and the 1500 have been resolved. And so a lot of times what happens is these 1500s don't get the attention because we're trying to collect big dollars to lower accounts receivable, or there's some features on here that aren't quite apparent to people. And so sometimes I ran a business office for a few months just as a favor to a client, and we'd have to declare 1500 day where all we did was go in and work the 1500s just to get them out the door, just so we could generate those patient bills and get them resolved.
Okay.
So the billing function, these EHR software pieces, and everybody has their opinion of the billing software, but really what they've done since the advent of the electronic health record is they generate claims automatically for us. If Angel came in, got an x-ray, the right charges dropped, and everything was formatted properly, 5 days from now, Cerner would generate a bill on our behalf, and we wouldn't even have to touch the claim. So we end up managing the claims generation process Back in 1980, we probably had to type out and fill in those lines and understand what was in each piece of it. Now we're in a process of reviewing for errors because the software is going to generate as much as it can automatically. So the Cerner example is edit failures. If we tried to generate 100 bills and 85 of them went out the door without any human intervention, 15 of them got stuck in an error status. And so our understanding of the billing process and the requirements is critical because we want to go in every day. One of your top priorities at any facility you're in is to go in and fix the errors on the claim so they can join their other 85 friends that are out in front of the insurance company getting us paid. So we're billers and follow-up reps for sure, but really we're just in a troubleshooting status to figure out what was supposed to happen on the claim and why didn't that happen. We review bills then for proper formatting and any required attachments. Wyoming sterilization processes for Medicaid is a great example. Every time a Medicaid patient decides to have a tubal ligation, so they don't want to have any more kids, there's a required form that has to go with it. So we developed an edit error that says if you see that Medicaid's the insurance plan and we have one of these procedures, I don't want you to send out the form because it's going to be denied because we didn't send the required attachment, right? So this is what we call working on the clean claims percentage because we want as many of those to go out cleanly to the insurance company. If it gets denied, they deny us 30 days later, then we start this troubleshooting process, and then we send the claim back to the insurance company. We're no better than 65 or 70 days. But if we took a day and found the right requirement and then sent it out the door with the right attachment, we get paid in 35 to 40 days. So we can cut a month out of the entire collection process. So one of the errors in the system now is to say if you see a Medicaid claim for this type of procedure without an attachment, I want you to hang on to it and let me upload the attachment with the claim. And then the last piece that we try and accomplish is electronic transmission. The secondary claims are a hard thing to process as an example. So when we talk about secondary insurance, I am 62 years old and I'm working and my employer still insures me through Cigna. When I turn 65 and I'm still on the job, I'm eligible for Medicare, and so my primary insurance would be Cigna, but my secondary insurance would be Medicare. And there's a lot of data that has to go into sending secondary claims because they want to understand how Cigna approached the payment. And conventional wisdom was we'd print out a copy of the explanation of benefits from Cigna and drop it in the mail. Now we can transmit all of that data to Medicare electronically. So do you think we're going to get paid faster if we mail it or if we send it electronically?
Well, I've been doing that for Medicaid.
Dropping
because they require paper. They require paper. Yeah.
So there's some situations like Medicaid adjustments where unfortunately that's the only way they'll accept it, even in 2017. But we want to prove the example, I threatened to lock up one of my biller's envelopes, right, and say, you got to come to me to get the key. And when you come to get the key, we're going to talk about, are we absolutely certain that this has to go paper? Because if there's any way to send it electronically, we're going to get paid 30 and 45 days faster. So Medicaid's a great example for those ones that have to go paper. They don't even upload their own paper. They send them to a vendor that turns around and then uploads them. So if it takes 7 days to get there in the mail, and then they save a batch of them and send them over to a vendor that scans in the claims into their system, and then there's some notification process back from the vendor to tell them, hey, that claim's there and it's ready to look at. One payer told me that the lag time was at least 45 days from the day I dropped it in the mail. Or if I send it electronically, it goes out to my claims portal, and then if I fix it in my claims portal, it's there in 2 days at the insurance company instead of 45 days, and it's in a format they know what to do with. So you're dead on. You're absolutely right that there are claims that even in 2017 we have to send paper, but we always want to ask the question, why is that? Are we sure? And have we seen the rule? We haven't just, my friend Billy, who's a pretty good guy and I go to lunch with every day, told me that it had to go paper. I used to work with an engineering firm, and we always said it doesn't count unless you can prove it, right? So just have that standard in the back of your head that what would I do if I had my envelopes in a locked drawer, right? Is this one that we for sure, because it has a huge impact on whether or not we can collect it. So then the last pieces are a little bit easier. It's in front of the insurance company, and our software sets reminders for us. Ideally, what happens is that comes back and gets paid, and then it goes to our friends in payment posting to apply to the account, and it goes to the patient for their portion or deductible. Sometimes what happens is it stuck in the payment portal and nobody realized it, that it was in an error status, or it had some bad data, and so Cigna didn't ever touch it. If you and I ran insurance companies and you got a claim that you didn't like, we would send a notice back, and some payers certainly do that. But Cigna, as an example, says if it doesn't match up on what I call 4 squares, so we understand the patient name, the patient ID, the subscriber relationship, and I think it's name and address. If those 4 things don't line up for us, we just throw it in the electronic garbage can, and so you don't ever hear from them, we don't ever get paid, and it's just gone into cyberspace. So Cerner, as an example, and most software does this, will set a reminder bucket that says, hey, you sent Lorinda's claim out 45 days ago and we haven't heard anything from the insurance company. Then we go through our processes and try and figure out what's the status of the claim. Do they have a problem with it? Did it get lost into that black hole? Then they send us what's called an EOB, and I'll take you through a more detailed explanation of this in a second. But this is, you're a patient, you've seen this a lot from your insurance company. This is just a detailed description on a line-by-line basis of what happened or what their opinion was on the claim. So they either pay all of it, deny all of it, or some combination of the two, right? If we send them a claim with 2 line items, Angel got a lab test and an x-ray, and they paid the lab test and they denied the x-ray, we'd have a payment portion and then a denial that gets flagged to say, hey, they didn't like the x-ray, and then we have to figure out what the process is to generate a new bill to go out after the money from the insurance company. Patients sometimes will squawk and they say, my God, I was in there in September and now it's February and I'm just getting a bill from you. And one of the things I like to say is that's because we're appealing these denials on your behalf. you signed a paperwork that said you'd be responsible if your insurance company didn't cover it, and we don't want you to have to pay that. So we submitted it back through the system for the insurance company with notes and the appeals as a favor to you. So trust me, nobody's more enthused about getting paid for our services than we are. We just unfortunately have these relationships with the insurance company, and sometimes we have to go back and fix those claims or help them understand why it's important that they pay. And then the rest of this isn't represented on the face of the claim, but good payment posting impacts your job. If it was $100 and they wrote off $5, and so we should have applied $95 to the account, but they only applied $90, we'll have a $5 discrepancy, and it will look like something that you have to resolve, but it may just be a posting challenge that happened. So accurate payment posting, we sign up with as many insurance companies as we can to get electronic remits, so we can post those electronically instead of by hand. It helps us with the speed. If you've ever seen Andrea stack, those remits sometimes are 60 and 70 pages thick. So we can automatically post a good deal of the payers, and some of them we still have to do by hand. And then when the insurance company's all done, we send them, the patient, the balance bill, and we can make payment arrangements with them, or they can avail themselves of our financial assistance policy. So UB, a lot more complex because we have a lot more departments that we're trying to bill for. The 1500 is pretty straightforward. And then the only thing we didn't cover, because it's a pretty detailed thing, and we'll look at it in some of the technical denials next week, but our occurrence codes, condition codes, and value codes, and those hang out in this section of the insurance bill. And if you think about it, they're essentially there to tell us what happened. My mentor, Shelley Larson, says the insurance bill actually tells the story of everything that happened to the patient. We've got 70 and 80 pages of documentation, and in one-page form, we tell the insurance company everything that happened. And that the detail of what those are and when you should use them, there's a couple of good resources. In your office there, as an example, you have a uniform billing editor. It's both a bound copy and if you're really in luck, which you are at Hot Springs, you have an electronic version. It's stored on the network. It's the difference between good billers and amazing billers are comfort with the uniform billing editor, because they give us great detail about occurrence codes, value codes, anything that happens on the face of that claim. You can find a detailed explanation of what it is, why it matters, and what's the correct number. Noridian has adopted a cheat sheet, and we're big on cheat sheets at RHP, but Noridian has adopted a cheat sheet, and so we've included a good link here for you to that. You can save that link to your computer and then use the Control F feature to search the Adobe document. Are you familiar with Control F?
Yeah. What document did you say that was for?
So it'll work on any internet document or Adobe document, but in this example, if I hit Control F and said show me the occurrence codes, it'll take me right to the occurrence code section. So a lot of folks,
that's in the uniform billing editor?
Yep, that data is also in the uniform billing editor. And I'm sure they've shown you this, or otherwise when we hang up or the next time I'm there, let's find the links to it on your network. But that's a great, great resource. This is just another example for hospitals that don't have the subscription, because that's a pay service. And so the other way you can get at that data is this Meridian Quick Reference Guide. So if we think about the 50,000-foot overview on what we're trying to accomplish, we've shown you how the revenue cycle impacts different areas of the claim form. We'll talk about common types of bills and understanding an EOB, and then where to find that. Gets you where you need to find information if you call the insurance company. I put a big bold if there because calls to the insurance company can take half hour or 45 minutes. And if you look at industry standard productivity numbers, they say we expect a biller to get through about 50 claims a day. So that's a claim every 10 minutes. And so if you have to spend 30 to 45 minutes on the phone with the insurance company, we're already behind 2 claims, right? So we want to use as many of the electronic tools we can to follow up on claim status. And if we have to call the insurance company, there's a good slide here at the end on how to be more targeted if that's something we're going to do. And maybe we ask questions about 5 or 6 of the claims at one time. So instead of 1 claim in 40 minutes, I'm answering 5 claims in 40 minutes, and that gets me back into that 10-minute target that we have. And after this course, we've got some cheat sheets for billing that we'll send out.
Okay.
Sorry, my allergies were giving me grief. But in general, our preference is portals versus calling, electronic delivery versus paper like we talked about. The next one, not sending a claim more than twice if they tell you, well, that claim's not on file. So a great example is we talked about that tickler file that just said Lorinda's claim went in 45 days ago and Cigna hasn't paid us or sent us a denial or anything. It's common because the insurance company wants to hang on to their money as long as possible for them to just take that data and say, yeah, there's no claim on file for that patient. And our reps, because they're good and kind and believe the best in everybody, just turn around and say, well, okay, I'll send you another copy. But when you think about it, you have some of the best software in the world at your fingertips. And Payment Portal, as an example, even gets a payer acknowledgement from Cigna. They transmit that claim to Cigna, and it doesn't go to a black hole. The insurance company's computer looks at it and sends it back and says, thank you, we acknowledge receipt of Lorinda's insurance claim. So if you've got a receipt that they got the document and yet we call the insurance company and they say they don't have it on file, the definition of insanity is doing the same thing and expecting a different result, right? So instead, we don't want to let them off the hook by just saying, hey, I don't have any claim on file. We want to follow up and say, you know, that's bizarre because I've got an acknowledgement here. Can we think through what else might be going on with the claim? Because if it's there and they just aren't putting their finger on it, it's always faster for us to get paid than it is if we have to turn around and send them a new claim that'll take 30 more days. And then the nightmare scenario is they may register it as a duplicate of that claim that's actually already in their system. So we talk a lot about truth-telling. They're good people doing their job just like we are, but they have different incentives than we do. And A, having confidence in our software, and B, confronting them with things like payer acknowledgement receipts, you can get let down to those questions of why is that happening? What would you do if you were in my shoes? And not let them off the hook. And sometimes we can solve that problem instead of them just trying to dismiss you off the phone and saying, well, send me another copy, right? So I know we're running long.
Does that happen a lot?
No
with
claim on
insurance
file?
companies? I mean,
Uh,
that they would try to stall you.
well, so there is no evil plan for them to stall us, but examples of them doing that are like Cigna's process of just throwing the claim away instead of saying, hey, we denied this because I couldn't find anybody with that ID number. Or every spring, Medicaid changes their rules because they know it takes us a while to retool our accounting software. And then if it gets denied, it takes longer to get paid. And so they made money on the interest. So there's no dastardly plan, but if we understand what their incentives are, and it absolutely happens that they change the plan or change the policy or change the HCPCS code because they know it'll generate denials and hang on to claims. Um, and you know, that insurance rep that you get a hold of, we like to think of the insurance company as sophisticated because, and that they're all wearing suits and ties because they're in a big expensive building, but they're in the same spot we are. We just have to coach them through. It doesn't make sense to me that that claim didn't get there, right? Because I've got an acknowledgement. So let's try a little harder and figure out what else might have happened to the claim or what, because worst case scenario, you go through all the boxes, we hold their feet to the fire and they say, yeah, I just need a new copy. We want to understand what we're going to do differently, right? Instead of just duplicating the last result where it didn't result in a claim on file either, right? So can I fax it to you and you can acknowledge receipt of it, or is it a problem with the payer ID? Can we check eligibility? What are we going to do the second time to make the result different than the last one? Because the last one I sent, I was confident it got there too, right? So you'll hear folks talk about type of bill a lot. That's another thing that's explained in really great detail in the UB editor. What we've done here is just given you a summary. And the reason we have types of bills is because you have PPS hospitals like New York General, right? And we have critical access hospitals like Hot Springs that are paid at a different rate. We have a lot of different things in multiple departments of the hospital all being billed on one claim. And so we have to transmit all of that data by altering the type of bill, which always shows up in the upper right-hand corner of that institutional claim form. So it's a 3-digit system for all common purposes. I put down here the 4th digit because technically if you read any of the guidance online or in the UB editor, there's always a 0 out in front of this. But number one, we don't print the 0 on the claim. And number two, if I'm effectively working with 3 digits, I like the notion that this is a 4th digit. It's just the last claim. So the first digit indicates what type of claim it is. So 1 means inpatient.
Okay, wait, where are you at? What digits are you talking about?
The very first one here. The first column.
Where is that at on the claim form?
Type of bill ends up in this upper right-hand corner here. So you'll see a 111, which means an inpatient acute first bill, or an 851, which means an outpatient lab first bill. But the type of bill here then tells us what type of claim form we sent them. Swing bed 1 means it happened in the acute side of our hospital, but 8 means it's a swing bed claim instead of a garden variety claim where I got pneumonia and they put me to bed. You'll see 141 as a reference lab. So if Basin Clinic for Hot Springs, we're using a lot of Hot Springs examples today, folks, but hopefully you can track. If Basin Clinic sent us lab tests that's actually owned by the facility, right? So even though the blood got drawn outside of our hospital, it was done by our hospital, and so we could bill that lab on an 8.5 example. If Red Rocks drew the blood and sent it over, it wasn't drawn by an employee, so that's called a reference lab. So you can see lab tests done in our hospital that are an 851 or a 141, depending on the location where the blood's drawn. The biggest thing to remember and to learn here about type of bill is that the third digit is where the meat and potatoes are. And what I mean by that is every time we send a new claim, Scott came in 5 days ago, and I'm sending Blue Cross a bill for the first time for a lab encounter. It's going to be an 8.5 for an outpatient lab, and then the very first time I generate it, it's going to end in a 1. But if they denied that claim and we had to send them changes to the bill, we got the wrong CPT code in there, or something else was wrong on the face of the claim, the next time I send it to them, it has to end in a 7 because I'm replacing that original claim that I mailed to them. A lot of times what happens is our software has a billing rule, and it goes out with an 851, we're that last reasonableness check, and somebody doesn't look at the type of bill. And so the second bill goes out the door with that 1 in the final position. They're going to send us a denial for a duplicate claim saying, you're crazy, you've already sent us a claim for this data service for $400. This has to be a duplicate. And it'll make you pull your hair out until you realize, well, that's because I changed the circumstances and I'm really sending them a replacement claim here. So mastery of these type of bill numbers is a real subtle thing, but it makes the difference between a good biller and an amazing biller. One of the first things we solve at a lot of hospitals is a trainload of denials for duplicate claims that rest solely on this notion of not understanding what we're doing, what claim in the sequence this thing represents. So you've probably seen EOBs as a patient. You may have worked on EOBs in your time at the facility already, but I like folks just to have a common understanding of where the data is. Again, either because I need to mine an EOB for the data we send them on secondary claims, or because I'm trying to interpret what's going on, why the heck they've denied this claim. So all the data about, if you look in your system and they say, we got paid from Medicare on May 31st, this is how you identify the May 31st remit. The blue section, if this thing was 48 pages, we could hit Control F and search for Angel Anderson, and it would get us to the first position where Angel was listed as the patient. This middle section is where we find out all the stuff about Angel, her name, her insurance number or HIC number, health insurance code, and the account number is our claim number. So if you had 9015746, you could take that account number and go back to Cerner and look up, tie the two accounts together. That's our common link here. When you talk to the insurance company, you'll always talk about the patient, their number, total bill charges, or the claim amount. Sometimes one thing to be wary of is that the claim number with the insurance company, they generate their own claim number. That's what I call the ICN, or the document control number. We'll send you a cheat sheet on this, so we won't spend time on it because we're almost out of time. But one of the things we have to do to help the insurance company understand a replacement claim is to put a document control number on the second return that says, here's the denial the first time you saw this, and here's the unique document number. That document number is right here on the explanation of payments. It's called the ICN or the DCN. And then the purple things here are line item details for what happened on the claim. So if we look, we now know that 851 means this was an outpatient lab. And so we billed them for two separate line items here. And so if one of them was paid, CO 45 means that's just the amount we're not touching because we have a contract with you. So 45 says it exceeds the fee schedule allowable, and 253 is because the federal government's still broke and they take what's called a sequestration adjustment. We ran short of money, so even though we should have paid you everything but this $2, we're taking another 2% off the top. So they paid us 100% of what they were supposed to on this line item, and then they denied us for this line item. And so you take the adjustment and the adjustment codes, and you look to the bottom of the claim to understand what they denied for. Now, if you're on Cerner as an example, you'll see this 97 in the billing software on the insurance denials tab, and you don't have to get to the EOB. But if you're looking at an EOB and trying to interpret what the heck's wrong with it, this 119 of the $183 we sent them, they denied $119 because the benefit for this service is included in an allowance for something else that's already been sent to us. So real easy concepts, but real important and a quick way to break down an EOB and understand what the heck's going on, what we're reading, what the insurance company didn't like about it. EOB, explanation of benefits, or availability, if you're on availability, they call it an explanation of payments, or ERA, electronic remittance advice. That's all terminology to stand for this communication from the insurance company. ICN or document control number. And finally, I put the list. We're going to have a cheat sheet on this because I've changed my theory here. But I used to just give people a list to the, so if we got denied for 50 as an example, they put a code. Now the link's not working for me, but they put a code on there that said 50, and I didn't have access to the bottom of the claim form, or I'm just looking at it in my insurance software and I'm trying to understand what that means. There is a great website that I recommend every new biller bookmark, and it walks us through every reason. So even for insurance companies, they understood that a while ago it was just calamity if everybody had their own rules. So they got together and adopted what's supposed to be a standard list of denial codes. So if you had this bookmarked and you came in and said, help me find denial code 50, you'd jump right to it, and it would tell you that this is one of those that we talked about. We're not going to pay you because I don't think it's medically necessary. You ordered an arm splint for a diagnosis of a runny nose. So as you're getting used to EOBs and you're getting used to solving technical denials, this is a good resource that helps you stop short. Why do I say stop short of getting the EOBs? Sometimes it's not an elegant storage mechanism. Sometimes my poster will save it in the day for the 24th because that's when she worked on it. But that payment date on the EOB was for March 17th. And so it takes me a long time to get through there. So I'm always looking for shortcuts to figure out what's the easiest way for me to carve through all the BS and figure out what's going on with it. And one of the ways you can do that is just by that denial code in Cerner and then the cross-reference out here on the website. I'm going to wrap this up because we're at our hour allowance, but I will update that link. This is just a little summary of what we talked about. Are we sure that we can't use, we'll show you in another class how to use the electronic claim status feature. Again, how much can we do without calling the insurance company? Because I expect to be on the phone with them for 15 to 20 minutes, and that already puts me over my 10-minute budget per claim. If we do have to contact them, what can I do instead of solving Scott's Blue Cross problem and then going to Angel's claim and understanding Angel's got a Blue Cross problem and calling them back? What can I do to maximize my call so I have got 5 to 10 claims for the insurance company lined up, and I can just march them through all of those at once, and then always getting a good call reference number and document. So when you win the lottery and you don't show up to work tomorrow, everybody understands what the last step you took.
Okay.
Right? And then this is that notion of you don't understand what's happening to the claim, and the guy gives you a random number and just says, you got to send us another claim. I don't know what to tell you. Don't let them off the hook. And what can we do? What would you do if you were in my shoes? Explain it to me. I say explain it to me like I'm two a lot, right? Because you don't want to invest that 40 minutes when you get 10 minutes to resolve a claim and not hang up without a crystal clear understanding of what's going on. So I will tell you that being a biller seems like an overwhelming deal. One of the best billers I've ever come across in the entire region was 22 years old with no prior experience. But she was great at reading comprehension. She was tenacious as far as not letting those folks off the hook, and just had a good way of organizing her day to work through those claims in a timely fashion. So good reading, comprehension, tenacity, and drive. Everybody wants somebody with 20 years of experience, but it's not a requirement to be a rock star biller. I always say, I've figured this stuff out, and if I can figure it out, anybody can figure it out. Don't duplicate the same action, sending them another climb and a different result. Look for trends and errors. If today you had to solve 50 lab claims that had the wrong revenue code, and you come in tomorrow and you have to solve 50 lab claims that look for the wrong revenue code, we're always looking for errors in the software that we can push back and have it changed so we can get back in that supervisory troubleshooting role and not what manual workarounds. Manual workarounds will kill your claims rating. Don't be afraid to ask why we do this. There's my threat to padlock envelopes. Let's just make sure, because of that 45-day difference in how fast we get paid. And then my boss at an engineering firm once told me the only thing that matters is follow up, and follow up, right? So that's the hour-long intro. I think I promised you 45 minutes, but I tend to ramble a little bit. What makes sense? What questions do you have?
It did make sense. I don't really have any questions yet.
Okay.
I have more questions about navigating through Cerner.
Sure.
Or how to fix claims that are wrong. Or
perfect.
But I'm training. It is overwhelming, and there's a lot to learn, and I'm tired of training.
Sure. Well, just understand that, like I said, if I can do it, anybody can do it. And ultimately, the whole story is on that piece of paper. And we're talking about a relationship between us and the insurance company and us and the patient. And these things are knowable and solvable. So there are binders and manuals and rules and websites to learn. But at the end of this day, like I said, 22 years old with no prior experience, because you just have to be committed to understanding what's going on, and then how do we push that through back to the insurance company. So we're going to break this into 2 or 3 more sessions, and then in the follow-up ones, we're going to work on some tips and traps in your billing software, and how to fix claims, how to look at claims, loops and segments, and that kind of thing. So we'll get there, or your hospital will get there, or both.
Okay.
And I'll email you a bunch of these cheat sheets that I refer to after we get off the phone. I should let you get some lunch. Thanks, Angel.
And what would be helpful, since you're going through this training, is having some, I don't know if you have mock software or mock claims that can be worked on, or I could guess what's needed and do it without it affecting a real claim. That would be super helpful. Yeah.
You bet. We've got both, right? We've got access to, and your notion of mock software is awesome, because we need to have it de-identified so anybody can look at it without signing a BAA agreement. I also don't mind working on live claims, because I hate training time for the sake of training time. If you need to get 50 claims done today and we just took an hour, you've got to figure out a way to pick up 6 of those claims, unless your boss, which she does, understands that there's learning curve and training time. But if we can understand concepts and work on live claims, then we're A, training, and B, getting bills out the door for your hospital at the same time.
Yeah.
So as many times as we can, we'll look for real live examples, and then we'll just limit distribution for who has access to this. So not anybody outside of Hot Springs would be able to use it. But yeah, that's a great point.
Okay.
Well, I appreciate it.